Okay, I guess I'll start. Hi, Dr. Champagne. Is that correct?
Sorry, I just
Um, did I say it right? I
okay.
just want to make
Yes,
sure.
yes, yes. Sorry,
Champagne,
I just
right?
realized I muted myself
Oh,
before. Yes, okay. Yes, it's Dr. Champagne. Yes.
okay, yes. All right. Hi, Dr. Champagne. Thank you for accepting to be a guest speaker on the CyberClinic Podcast. Um, Dr. Champagne is an award-winning neuroscientist, therapist, educator, and social worker whose work has had a profound impact on the vulnerable and complex populations. She is nationally recognized for her innovative design and implementation of programs that support families facing the multifaceted challenges of fetal alcohol spectrum disorder, which is FASD, childhood trauma, attachment difficulties, and aggression in childhood. Her work doesn't just sit in academic journals, it is translated into practical training and real world change, making her one of the most sought after bilingual trainers in the field. As a keynote speaker, author, and change agent, Dr. Champagne bridges the gap between science and compassion to elevate care, understanding, and resilience in both families and professionals. Whether you're a clinician, policymaker, researcher, or educator, today's conversation promises to be a compelling, in-depth exploration of neuroscience, trauma, resilience, and the future of behavioral health. Again, thank you. Welcome, Dr. Champagne, and you in the audience. Thank you for being here. Dr. Champagne, would you like to put in a few words of of your own?
Yes, I would say that I'm first and foremost a psychotherapist, and that was my first passion. And then I realized that it's really good to know how to evaluate programs, especially asking people who are using our services. So that's how I became really interested in program implementation, program evaluation, and decided to do my PhD. Um, but to me, my main focus is to make sure that our research and our programs are really impacting the quality of life of the people that we serve. So that's it. The main thing about me, I guess.
Good. Yes. Let me start asking you about your journey, because the story behind your work is just as inspiring as the work itself. Dr. Champagne, can you share what inspired your journey from neuroscience into social work and therapy, and how these disciplines complement each other in your practice?
hmm I love this question. So like I said, I'm first and most, first and foremost a therapist. So I was in social worker, and I've always worked with families who have children with special needs, different kinds, but mostly fetal alcohol spectrum disorder. And this is an area that's highly stigmatized, where there's a lot of intersectionality involved. And I really wanted to learn more about, like I said, how to support them, how to evaluate their programs to make sure they are really adapted to what the population needs. So I decided to pursue my PhD studies and then just understanding more about what it means to have an evidence-based program and also how our brains are impacted by what we experience as caregivers. Especially in my field, I usually refer to caregivers because we're referring to parents, adoptive parents, foster parents, parents from birth. Um, but we usually refer to anyone who's taking care of a younger person.
Yes. I have another question here for you. You've received national recognition for program design and evaluation. What do you believe sets successful, impactful programs apart from others that may have fall short that may fall short?
Mm. When I received this award, like the story behind it is when I started my PhD studies, I received a grant to assess how families who adopted a child with FASD were coping during the COVID-19 pandemic. And as we remember, I don't know what the rules were in some of the states, in the United States, but in Canada where we lived, A lot of our kids were not allowed to go to school anymore. Everything was virtual. And the structure that our kids had, the services were all stopped. And families that had children with FASD that were kind of staying afloat were actually drowning. And what we saw is like escalation in difficult behaviors. Some of the parents had to find different kind of placements for their kids. Like things were quite dangerous for some of them. And all family members were traumatized, including the kids that were impacted by complex trauma or neurodevelopmental disorders. So, I was really concerned about further stigmatizing people who are neurodivergent, who have a neurodevelopmental disabilities, but I know that these individuals thrives on structure that did not have anymore. And that was really impactful. So impacting for all of them. So they said, yes, we would like you to find some solutions. So that's when we thought, okay, usually when you have a research, you find a problem. It takes about 15 years to hit the ground, to hit the people who are impacted by this problem. And so it's not like you have 15 years to help
Right.
these families. So we had another grant where we said, okay, let's figure out what we can do. And then we found a program called Nonviolent Resistance in the UK. And it's an evidence-based program. And it's also for at its core, nonviolent resistance was used by Gandhi, Martin Luther King, like the whole resistance movement, but it transformed it into a family therapy. So I interviewed a few parents. They all said, it's not perfect, but it's the best we've got. And
Right.
so we did the first pilot study in Canada using NVR for these families, and it worked really well. So I approached different organizations and I said, what about we launch this program? So it was all about, I did get the award, but it's like several people were really passionate about this work and we said, yes, we will try it, even though we're not 100% ready and we don't know if this is going to be, like as good as we hope, but we did it. And so that's kind of like how it happened. Like they felt like it was groundbreaking breaking because it was new in Canada, but also because these steps happen very quickly,
Right.
while usually from, okay, we have a problem, we need to find an intervention, like we tested for a long time, and like it takes so long for people to go, yeah, finally we have some solutions, right? So that's how I received the award. And we're still very much, I mean, it's years ago, but we're still very much looking at different solutions for
Right.
this systemic issue.
And that sounds like something that was well deserved.
Thank you. Well, our whole, and it's, yeah, I mean, they gave it to me, but honestly, there's a whole team behind research and behind program implementation. It's never a one person endeavor.
Right. It's a teamwork effort.
Yes, very much so.
Right. That leads us directly into your expertise, because so much of your impact has been around supporting vulnerable children and families.
Mhm.
You are known as a leading expert in fetal alcohol spectrum disorder, FASD. What do you think are the biggest misconceptions about FASD today?
Mm. There's so many. I think the first one that I usually like to address is the facial features. A lot of even medical professionals don't have a lot of training on
Right,
FASD, and they would think that you can really see it on someone's face. And we know from research that only 10% of someone who could be diagnosed with FASD has the facial features. So we're talking about the thinner lip, the philtrum here, and their eyes are a little bit more spaced out, but only 10% of them. So it's not a good gauge of knowing if someone has it or not. I guess the second thing, and it's really related to my work, is not everyone who has FASD will end up in jail or display aggressive behaviors. I know
right,
many people with FASD who live great lives with support,
right,
right? I
right,
mean, they have a great sense of humor. I've been passionate about supporting people with FASD for 20 years because sometimes I have a session with them, my cheek hurts because I have such a great time with them. And yeah, I'll enjoy their straightforwardness. Um, so sometimes I think the way it's portrayed in the media is extremely negative. And it's true that without enough support from society, it's possible that they will fall through the cracks. But many of
Right.
them live a really good life, good quality, have a good quality of life and good outcomes if they have the support that they need, and if they live in a community that want to support them.
Right, to be of support to them. Yeah.
Mhm.
As an extension to that question, I probably have that question maybe in some of the other ones that I will ask you later. But does that cause an impact on pregnant women who suffer from FASD?
Um, do you mean if the mother has FASD herself?
Correct.
Yes. Okay. Oh, that's a good question. So, and it's a question that I'm being asked this question very often. So if, let's say, a mom has been prenatally exposed to alcohol herself, she likely has a brain-based disability, and it may even have affected some of her organs. So she may have health issues based on the fact that she was prenatally exposed to alcohol. And some of these issues that could be cognitive, that could be body-based, could be passed on to the next generation. However, if she doesn't drink at all, they won't be diagnosed with FASD, right?
Right,
But it's
right,
still, let's say she has heart issues based on that, it's possible it's going to be passed down. Or the
right,
brain or child could be different.
right.
But there's other components, like it's usually multifactorial. So if the mom she had FASD, very possibly she doesn't have the same buffer to stress as another person, as a
Right.
neurotypical person. So she may be experiencing a lot of stress during her pregnancy, maybe a lack of support. So it will impact the developing,
Okay.
baby, right? And
Right.
also sometimes we forget that the partner has an impact. So in heterosexual couple, if the dad has been using alcohol, it can also impact the developing fetus.
Okay.
And it's usually something that's encouraged by the partner to drink or not to drink during pregnancy. So, it's often the burden's often placed on the mother, while the father also has an impact to play in these.
Right, in terms of support and that. Yeah. And how about the comorbidities, such as somebody who may already have some, let's say, high blood pressure or have a prior health issue, and then suddenly is now falls into the category of ASD.
Right. Yes. Okay. There's a whole body of research on FASD and ASD. I don't know about the United States. I will assume it's very similar, but in Canada, many children are diagnosed with ASD, autism spectrum disorder, instead of FASD,
Right.
because we have more funding and support for this diagnosis. So some medical doctor will go, you know what? Let's diagnose your child with this so you actually have access to services and support. The big problem is many forms of ABA, which is a treatment that's very common in ASD, does not work for someone with FASD. So that's when
Oh,
we
okay.
hit the problem, right?
Right.
And but there's usually less stigma around ASD than FASD, because FASD then it leads to people thinking, well, okay, your mother was drinking while you were pregnant. And
Yeah.
it's usually way more than only prenatal alcohol exposure. It's usually, developmental trauma, early childhood adversities. So it's really just the prenatal exposure to alcohol
Okay.
that to the brain-based disabilities.
Okay.
Child. So but you're right when you say there's a comorbidities. Now we're starting to see that it sometimes is the right diagnosis to say there's ASD and there's prenatal alcohol exposure that was
Oh,
impacting this person, right?
right.
It is a comorbidity for sure.
Right. Yes, indeed. In your work with families and children impacted by trauma, what early signs should educators and healthcare professionals be most attuned to?
Hmm. When I saw this question, I was like, oh, okay, like which one is the most prevalent? I think they all look very different. But in childhood, very often if you see a child that has um, severe emotional dysregulation, like
Right.
it's really hard for the child to accept co-regulation. So if the adult is trying to soothe the toddler, for example, and the child won't be soothed, that could be a red flag. Right? I think these
Okay.
are some of the early signs that we will see, like emotional dysregulation, like big tantrums that are really hard to soothe. Another one would be difficulties with attachment. So let's say the child gets hurt, and then the parent is approaching to soothe the child, and the child would refuse the
Oh,
parent
wow.
support. That's a big sign that there might be
Right.
some attachment issues. It doesn't mean it's the parent's fault at all.
Right.
It could mean that the child's either neurodivergent or the child has some level of trauma.
Okay.
But sometimes when they're really young, 0 to 5, it's hard to pinpoint what's actually happening. So sometimes it's providing services to the family, support them in even sometimes unmet basic needs,
Right.
see how that evolves, and also supporting the child, is it speech and language therapy? Is it occupational therapy? Making sure that if there's one parent or two parents, that they both feel supported, um, reducing the shame and what they may experiencing as parents when your child doesn't behave how society is expecting them to behave.
Right.
Another one that I think it's less understood in Western societies is the impact of communities, involving aunts and uncles, grandparents, neighbors, like other people in the community, so parents don't end up raising their children alone.
Right.
And that's something that's maybe not as popular in the States or in Canada, I would say,
Yes.
right? Like it's something very challenging when we say, look,
Right.
to reach out to other people. Like in Westernized culture, it's very much about raising your child alone and
Right.
doing it on your own, which when you have a child with special needs, it's pretty much like asking someone to climb the Everest on their own.
Right. Yes.
So,
Yeah.
it's usually harmful to do that.
Right.
Yeah.
Yeah. So that's to say there's a cultural component to this, because in multicultural homes, you don't quite find those situations, right?
Mm-hmm.
Because in the Western world, it's different. It's the same thing for elderly folks who tend to go to nursing homes because they tend to live alone in the Western part. But
Yeah.
when you go to the different regions, they are totally different. They do take care of their elderly folks. They live amongst them. They live with them. So that's totally different. So there's a cultural component attached to this.
Yes. And even when we discuss attachment, um, there are trainings on decolonizing attachment. We usually, when we give training on attachment, we say you have to focus on the primary caregivers, which are, most times the mother and the father in the family, and avoid having too many caregivers for the child, especially when they had attachment difficulties.
Right.
However, what we're seeing is it can be harmful on the parents because that's putting too much pressure on them to build secure attachment with a child that already has been harmed by other adults, and they may not
Right.
be able to develop this relationship. So that
Correct.
puts a lot of pressure on the parents and the child to develop that, which is not necessarily possible. What we've been seeing in terms of outcomes is everyone has a better quality of life when there's many caregivers involved who are safe and secure relationship for the young person, regardless of diagnosis.
Yeah, I understand. Um, how do you approach aggression in childhood differently when it is rooted in trauma or attachment disruptions compared to other causes?
Hmm. Yes, I think historically we have approached aggression as okay, it must be something the parents are doing wrong. Is it rooted in poverty? Is it rooted in, parenting practices? And it could be that sometimes, but very often what we see is parents are actually quite competent, but they're not given the services that they need to support their child. Um, and some of the young people that I've seen in my practice, they do have many services, and yet their brains are different. They don't have the same capacity for emotional regulation. So we need to, as a society, understand that we need a safety net for individuals who have brain differences that leads them to display dangerous behaviors.
All
And how
right.
we do that? How do we um, do some kind of harm reduction approaches for them instead of policing or instead of punishing? These things rarely work. If you have a brain-based disability, they need more support, not more
Right.
punishment. So that's the main difference. And I think a lot of the services for children and youth is child focused. And sometimes they would say, oh, it's family centered. But it's not really family centered because they don't provide services to the family members.
Right.
So if you have a child, let's say with autism, and every day they have big tantrums, they may hit you, there's property damage, and then both parents are traumatized, the siblings are traumatized. How do you expect the child to recover if all the family members don't really want to spend time with this particular child because they're scared? So even though we have loving, committed parents, if they're traumatized, they also need to receive services in order to be well enough for themselves and for the child and for the other kids when there's siblings in the home.
Mm. Building on that, your reputation for designing innovative program is widely recognized. And I'd love to dig deeper into that side of your work. What are some of the most effective strategies you've used to design and implement interventions for complex families?
Mm. I think it's been really listening to families. People rarely do that, and that's my approach. I guess it's my
Right.
background in social work too, of like, okay, I'm not going to look at you and go like, okay, here's your problem and here's the solution. We've been interviewing countless families from different backgrounds to say, look, what's happening? What's your experience? What has been helpful? What has been harmful? What do you think will help your family? And they come up with very similar message. So these
Right.
are the answers. So like I said, we tried it out and it's not perfect. So we go back to the families again, what was helpful and what we tried, what was not helpful, and having this constant interaction to improve what we do. Um, it's what I do is mostly qualitative research. We have some quantitative data, but there's a big focus on listening to the voice of people with the living experience. Um, I think that's how it's been successful so far. I mean, it's not perfect. I don't want to pretend in any way that our programs are
Mhm.
perfect. We really
Right.
want to improve for families though, and sometimes, it's not for everybody, right? There's things
Yeah.
that are not going to
Yeah.
be appropriate for this exact situation, and that's okay.
Right. There's got to be some level of passion involved in it, especially the ones providing the service, the
Mhm.
listening, making sure you understand where that person is coming from, the background and all that. The cultural aspect of it too might play a role in treating people, I guess.
Yes, for sure. Like we have um, many diverse families in our program. We have a Ready Plus program. So it's called Racial Equity, Diversity, Inclusion, something like that. It's like
Right.
a new acronym, so many acronyms.
Right.
And they really look at, okay, what else can we do in our program to make sure, it's accepted in, for example, indigenous communities in Canada. And sometimes they just approach us and say, oh, this is a very common issue in our community as well. Like what can we do? And we just say, here are the things that we do and what would suit your culture. And so there's things that they're already doing. For example, in indigenous culture, um, they don't have to push families to support the nephew and the person in the next family, right? They're very committed to taking care of children as a community. Well, in westernized culture, we don't. So it's like the thing that we need to push. And then in this culture, that's something they already do really well. So they may go like, okay, you know what? There's this piece here that we don't really have that we want to develop based on, their specific community. And in Canada, we have many. If you look at the population in the Canadian map, we're all at the bottom, like very
Yes,
close to the and we have
right.
like
No far from New York.
yes, exactly. So like, and everyone, like, there's a few people up there, like in the
Right.
north,
Yeah.
and so they don't have a lot of services.
Yes.
And so that's how also like we provide services virtually. I never see
Or telehealth.
in person. Everything's virtual now. Yeah, we could call it telehealth. Yes. So that's how we reach out to families.
Oh, good.
Mhm.
Now, wanting to add to that question, do you integrate people of those communities, like the indigenous communities? Do you have them or some of them as part of the staff to better understand and convey exactly some behaviors or how people report certain stuff, as opposed to just studying and report to them and providing services to them? So I think integrating some of those people, some of those communities probably would make a big difference.
Yes, 100%. And so what we do at Interwoven Connection, it's one of the organization I work for. Um, it's also based on peer support. So every family is also attached to a peer support person who has the living experience. And sometimes it's
Okay,
based on where they live. Sometimes it's based more on um, their faith group, could be based on their culture of origin. Like we try to go with what they would like. And that makes a big difference in feeling validated, feeling supported, not feeling judged. Um, because we're so focused sometimes on like changing the child's behavior, but sometimes we are not able to change the child's behavior. Sometimes it's like, okay, if the child stays with this level of difficulties in their behaviors or, medical needs, how can we still be a support of the family to make it sustainable and make sure they have a good quality of life and don't feel judged by the system or feel like they're alone in this? And that's a big part of the resilience,
yeah, that's
not.
true. I guess that really makes a big difference.
Mm-hmm.
When programs fail to deliver expected outcomes, what do you see as the common pitfalls and how can they be avoided?
Hmm. Oh, I think what I've seen in program implementation, and this is more like my opinion than, okay, I'm not sure about the data on this one, but what I've seen, it's when, okay, so you have to always look for funding and you have to make sure you're reporting your outcomes. These things, I think some organizations, especially nonprofits, don't really see it as important. So what we've been doing is we get a lot of in-kind support from universities to make sure we have the evidence behind what we do. Yes, we're quick and going like, okay, we're going to try this, we're going to try that, we're going to ask people with the living experience. And these are the key ingredients, I think, for a program that's successful. But you also need the data. You need, to show your outcomes to your funders. Um, and yeah, I feel like nonprofits sometimes they struggle with that. I would also say that some people they wait too long like until they have all the perfect ingredients before they
Right,
start. And I'm like, no, you need to start somewhere, even if you start small and you build from there. And like I said, you need that constant interaction between the people that you're serving and the people that are providing the services to make sure it's adapted and that's actually meeting their needs.
right.
Yeah. So I think and it's also common to have programs that are not really like the researchers are telling the clinician, here's what you're going to do. and they're very rigid in the way they're providing the services, for your program and your data. And then you end up with a program that's actually not serving the needs,
Mm.
right?
Wow. Yeah.
Yeah.
You're not only a practitioner, but also a trainer and educator, helping others step into this work with great confidence. You are a sought after bilingual trainer. How do language and cultural context shape the way trauma, attachment, and FASD are understood and treated?
Mm. Yes. There's a lot in this question. So let's start with FASD. For example, from in Canada, from one province to another, there's very different level of services and understanding of the condition. So for example, where I'm from in Quebec, there's very few people who understand FASD. Most pediatricians are not informed on this condition. So there's a clear lack of diagnosis and support. While in British Columbia, we have specialized social workers in FASD. Most pediatricians are aware and they are more open to giving a diagnosis to a child because they know they'll be receiving the proper support. Um, so I do think that with FASD, you'll have different level of supports across the province, across different provinces or different regions. And it is based on culture because it depends what the culture of the province is prioritizing in terms of health issue,
Oh, okay.
right? Or being able to recognize. Um, so for example, in Quebec, because we're francophones and we are a minority among
The
tons of
rest of the,
it,
yeah.
right? Yeah.
Right,
So sometimes the information doesn't come to French Canadian as quickly as to the Anglophone. So
right,
sometimes there's a gap there,
right,
like knowledge translation. Even
right.
me, like I'm Francophone, as you can hear, but like it's hard sometimes to get a grant to translate whatever it is that I'm doing. They'll be like, yeah, do it in English first because we have more people that we can reach
Okay,
out to, and then we'll have the French material. And sometimes
right,
the way we do parenting in Quebec and indigenous populations and like the rest of Canada is
right,
very, and we have an increased diversity in Canada, so it's also um, recognizing that parenting practices are different across cultures,
right.
and we can't go about it as this is right and this is wrong. Like if
Oh,
I
I
do,
see.
even
Right.
when the child has a disability, the way we approach disability in different cultures may be very different as well. In some culture, having a child with a disability is very shameful,
Yeah.
and in others, it's okay. Yeah.
Yeah, that's that I know in many different cultures. It's not by accident that they think maybe there's something wrong with this child and that maybe eventually that child should be strong enough to recover, but it's not always true. It's just that the lack of care, special care being given to them is not there.
Hmm.
Yeah. What advice would you give to frontline educators and social workers who are often the first to identify concerns but may feel underprepared to address them?
Hmm. What we try to say to educator is first, they need to take care of themselves.
Right.
I don't know if you have an increase in violence in schools in United States, but in Canada we do.
Oh
And
no, yeah, there's down here too.
yeah, I would assume. Yeah. And it's like, they need to be supported as well because they're humans and their
Correct.
nervous system is hijacked. So I think sometimes we would jump to advice on, okay, here's what you can do for the child. But sometimes I say you also need to get the support that you need um, for your own well-being, your nervous system. If you're around dysregulated children all day long, it's going to be affecting the way you're feeling at night for sure.
Yeah.
So first, and then the second thing is I think involving parents as much as possible. Some of these conversations are difficult to have, and there's a different protocol in each region or, administration thing, depending on where they work. But I think yeah, it goes a long way to approach parents in a way that's not non-judgmental, but in a way that is supportive. Like, have you seen some of your child's behavior? How can we support you in this? What else do you need for your child? And I think I have special needs kids myself, and I've seen some, I mean, we knew that, we were very open to discussing it. And I've seen teachers who were like really embarrassed to tell me about, okay, like this is what happened with your child. Like, are you okay? Like, they were really kind of vulnerable in those discussions. But I think,
Right.
and it's true that some parents may be defensive depending on where
Yes.
in that grieving process, but it's still really important to involve parents and not having them feel like we went in their back.
Right. Yeah. Are there resources available to them that you guys could just make available or provide to them within the very frame of their cultural habits or things that they may be accustomed to, which might make a difference in their dealing with those issues?
I could send you some resources. So, for example, for Feed Alcohol Resource Program, we have POP FASD. It's in British Columbia. It's evidence-based, and it's for any educator who is involved with children and youth in the school with FASD. And there's another one in the United States. I can't remember the name of it. That's more around children with trauma and how to have to support educators when they take care of children with complex developmental trauma.
Okay. Of course, your background in neuroscience gives you a unique lens, and I'd like to explore how that shapes your perspective. How has your neuroscience background informed your therapeutic work in ways that traditional training in social work or psychology might not?
hmm Yes. So my training is, they say neuroscience, but it's very much like behavioral neuroscience, behavioral science. Um, and what I think I've learned the most is how our nervous system is impacted by our caregiving experience. So I'll just gonna give you an example. We have sometimes we say, okay, like I'm not sure I understand this parent's reaction. Um, like let's say you're a parent, and okay, let's say I'm a mom, I have a new baby, I'll have a lot of oxytocin, okay, like attachment hormones. And I'm happy, it's going well, and my baby is cooing, and like they start, like maybe smiling to me, and I'm smiling back. So there's that level of reciprocity. So you have oxytocin and you have dopamine, and it feels good. Feels good being around your baby. Well, maybe at night, it's possible that you're like, okay, it's been the middle of the night. I don't
Right.
really feel like doing this right now, but in general.
Right.
And let's say you adopt, I also adopted children, and let's say you adopt a child with severe trauma, and there's very little reciprocity. So whenever you want to engage or screaming, they're positional, they name call you, um, they have a lot of harmful behavior. Like at some point, even if you're a very committed and loving parent, your brain will start producing cortisol. Not just your brain, your HPA pathway will have like a
Right.
lot of cortisol producing stress hormones.
Right.
And at some point, your brain is just going to go, you know what? Run for your life. This is not good. And
Yeah.
there's this confusion of like, I'm supposed to protect and love and care for this child, and they're harmful to me. So my brain's like, no, that's not good. And when I start understanding how, like, the role of hormones in caregiving, you tell parents, you explain that, and they're like, yeah, it makes sense. So it's reducing the shame because they're so embarrassed to say, I love my child, but I don't really like them right now. I don't really feel like I want to be around them. It's embarrassing to say, but when they know, you look, this is a normal reaction. There's things to be done around it. Not that you want to stay like this forever, but it's normal. It's
Right.
a healthy brain will tell you when there's a danger. And I
Right.
think that's the piece of neuroscience that can really help us understanding not only the child's behavior, but the parent's reaction to what's
Right.
happening in their home.
Right. Could you explain the latest research linking neurodevelopment, trauma, and behavior, and what it means for treatment approaches?
I'm not aware all of all of the field, but I think what's really new and what I'm doing and our team is doing is changing our approach to not being so child focused to being family focused, providing services to caregivers, building community around them, reducing the isolation, um, to improve outcomes. Children don't grow up alone on an island on a rock. They
Right.
have community, parents around them, and that's really where the shift is sort of happening. How we are also seeing attachment of like this may not be a case of one or two parents. It can be many adults caring for this child,
Oh, okay.
receive attachment. It's
Right.
these shifts that are happening in our communities that are actually very healthy. So these are the practices that we've been talking about more in our field and not
Okay.
being focused on specific child therapies. They're good. I'm not
Right.
saying don't do speech therapy, don't do occupational therapy. I recommend my clients to do it all the time. But how, as a parent, do you do all week long? Do you do that all week long with your child? And then you go home and you are not experiencing reciprocity with your child.
Oh,
That
I
won't be
see.
an outcome.
Right. Yeah.
Yeah.
As an extension to this, is there a remarkable demarcation between kids with siblings and those who are alone, like only kids, where the treatment would be different, or their reactions would be different, or their behaviors would be different? Is it more uh, is it better for them to have siblings or even friends who can always be around them to make a difference in the ways they act?
I love this question. Uh, I'll answer with the data that I have.
Right,
I don't know generally speaking, but in our data, a lot of adoptive parents, because most of my research evolve around adoptive parents, they have adopted several kids who are impacted by complex trauma and prenatal alcohol exposure. So you can imagine the level of support each child needs, and
right,
then put that all in the same family on one or two caregivers with little support. That's a
right.
recipe for a tornado, I tell you.
Wow.
So it's actually sometimes it's hard. It's really hard in some of these families, and their child protection system here really want to keep siblings together. While sometimes, I'm not saying all the time, but sometimes, especially if they've been harmed together in their family of origin, it's best to find different adoptive families who are going to be in touch. So they're
Right.
more cousins,
Okay.
especially if they harm one another, like aggressive behaviors towards one another. They just keep re-traumatizing themselves. That's harmful.
Right.
Um, So, I mean, it's not like I can say, yes, it's best to have siblings or not. It's more like what were the relationship between the siblings prior to joining this family and how traumatizing it is for the siblings or for even for the young person who displays these harmful behaviors. Are they re-traumatizing one another or is it helpful? And it's also the idea of voices in the family. There's often a voice that's stronger than the other ones, and sometimes that's the person with the aggressive behaviors, and siblings are forgotten, like and caregivers. There's a lot of
Okay.
met basic needs. So sometimes as a professional, you can look at what are the other family members' unmet basic needs, like in the caregivers. If there's an incident, do they have someone they can call? Do they have someone to talk to? Can they go on outings regularly with someone else? Maybe if the caregiver is not able to go with them. And maybe access to therapy, victim services for some of them. Um, yeah, I think that these are the elements that we usually try to look at.
Okay. Yeah. As we look to the future of care and research, innovation is playing a clearly important role. With technology transforming healthcare, what role do you see for digital tools or AI in supporting children and families dealing with trauma, aggression, or developmental disorders?
Hmm. Well, we've been using virtual platforms since COVID, and it has really been helpful. Like some of the families, they say, would like to go in person. So we try to provide that sometimes, but I think it really opened the door to families who are more rural in northern communities, for example, to
Right,
have services with many experts that they were not able to have before. So I think this is very positive.
right,
The other part too, I feel like there's many things that I can do with AI, which gives me more time as a clinician to spend with my families. So I think
right,
I'm not using AI, for example, for client care. But some of my tasks that are like making a report, for
right.
example, I can use
Yes,
AI, and then I have more time for families.
correct. Yeah,
Also, I feel like research, like when you do all those forms or research, AI is very helpful for that. Or when English is not your second language, AI is
right,
very. So I think for me, that's how I've been using it. I think this
right,
is great. There are some concerns about, as you know, AI, mental health, and how AI can just validate the person without saying, look, what about this or what about
right.
that? Right? Even in my field, sometimes we enter some information to do a bio or something. We're like, okay, AI, this is not what we're talking about here. Or I tried with AI to do like case studies where you say, oh, what if your child has FASD and they give clinical advice that are terrible? So, I don't think for clinical advice necessarily, but certainly to help with administration aspects of research and clinical support.
Right.
Yeah.
So, th- do you do or maybe your team, do you guys use the data that you can collect from what AI can just put together and tell you in helping you treating um different types of kids with different types of traumas or families and stuff like that. So does AI play any role in that part as far as gathering, or you have maybe different sources of gathering your data?
We use different softwares to manage our data. I I guess in research, how I've used AI was more like I have a report, it's already been analyzed. Sometimes I do ask AI, what else did I not see in terms of patterns? What
Okay.
else? You know?
Right.
And so sometimes the AI may suggest, what about this? What about that? And go back to the data.
Correct. Okay.
So for example, fa like the father experience, people identify as fathers, their experience of aggressive behaviors in childhood. We recently did a report and there's things I did not really see. And then asking AI, they're like, okay, what about this and that? And I'm like, oh yeah, okay, I see it now. Yeah.
Right. Looking ahead, what areas of research in attachment and trauma do you believe hold the most promise for breakthroughs?
Mm, I think I said it since the beginning, asking people with the living experience, involving the whole family. Um, Yeah, and I think we were very focused on diagnosis before, but now looking at this as with the lens of everyone's brain is very unique. What's different about this person? And not necessarily going, okay, this is prenatal exposure, this is that, right? Like not too much labeling, but more like thinking of how's the person functioning? How are they thinking about
Right.
this? What do they need? And what does the family need? And of course, having an intersectional approach. Like, what's their culture? Um, how are the parents feeling about this whole situation? I think that's the
Yeah.
future of
Right. That makes a big
child and
difference.
care.
Yeah.
Hmm.
Before we wrap up, I'd like to make this practical for our listeners, especially parents, caregivers, and policymakers who can directly benefit from your expertise. For parents and caregivers listening today, what are three practical steps they can take at home to support children struggling with attachment or aggression?
Mm. The first step, I think, is breaking the isolation, talking to people you feel like they will want to support you and not judge you and
Right,
help you navigate this journey. The first one is usually breaking the isolation. That's the first
right,
thing. Finding other people, find your community. Of course, reach out to professional who will believe your story. And I think
right,
that's the message for professionals as well. Believe them when they're telling you their
right.
story. Um, don't think that they're minimizing or exaggerating. Believe it.
Yeah.
And the last part would be there's plenty of resources on the internet. I just don't want to name all of them, but I will send you
Okay.
some resources that are good for these
Right.
specific
I guess they
reasons.
can also be open with their caregivers and feeling free that they can confine to those caregivers or health professionals and release some good information that could help them in their journey of looking for a remedy for this situation.
Hmm.
Finally, Dr. Champagne, what message do you want to leave with policymakers, educators, and healthcare professionals about the importance of early and trauma-informed intervention?
Yeah. Well, oftentimes policymakers are very focused on cost analysis. And what we've been seeing in this population is when you do a cost analysis of the quality of life of caregivers, this has the most impact on
Right.
children and youth. So looking at the needs of caregivers, like the parents, is crucial in what we do. And mm, thinking long term, the more investment we do in early childhood education, the more we won't see these entrenched dangerous behaviors when they're teenagers and adults. Um, yeah, and this is very well researched. So, yeah,
Okay.
investing in early childhood for sure.
Right. I guess before you leave, I'll ask the audience if they do have a few questions. Please feel free to ask questions, which really look forward. If you are not comfortable asking it, you can type it in the chat and I will read that for Dr. Champagne. So please ask questions. Sean, any question? Farah, any question?
Hi, Claude. Thank you so much for inviting us to the podcast. And it's a pleasure meeting with Dr. Champion, and I'm sure we this session is like really helped us a lot to learn and have more depth and information about the specialty of Dr. Champagne. Thank you so much.
You're welcome. Thank you for coming.
Thank you so much, Farah. Sean, are you there? Sorry, I don't mean to put you on the spot. Well, so Dr. Champagne, thank you so much for sharing your expertise and insights with us today. From your journey bridging neuroscience and social work to your groundbreaking contribution in FASD, trauma, and program innovation, you've given us not only knowledge, but also hope and practical guidance. For our listeners, whether you are parents, educators, clinicians, or policymakers, today's conversation reminds us of the profound impact that early trauma informed and compassionate care can have on children, families, and communities. If you'd like to learn more about Dr. Champagne's work, we'll share links and resources in the episode down on the website. You'll see she's got a book already on Amazon. and she's got article that she has shared with me, and I have posted that on cyberclinicpodcast.com. And to everyone tuning in, thank you for joining us on the CyberClinic podcast. If you found value in today's discussion, please subscribe, share this episode, and leave us a review. It helps us to continue bringing you conversations that matter. Um, I am your host, Claude Bernard. Dr. Champagne, I am so thankful. That was very kind of you to take your time out of your busy schedule to be with us today. That was very informative. And I will post this on LinkedIn. I will send it over to you first. If you like it, you can approve of me posting it. And I'll go ahead and make sure I do just that.
Thank you,
And that
Claude.
might not be your last time, because maybe in the future, I'll find out how much more work you have done from this point on going forward.
Thank you.
Thank you. Have a
Have
good
a
one. Thank you so much, the audience.